Good morning and welcome. Thank you for joining us today. My name is Samantha, and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are super excited for this opportunity to present to you the next installment of our webinar series, the 2026 CQM Playbook, How High-Performing ACOs Are Winning with CQM. Before we get started, I'd like to share a few quick notes to help you make the most of your webinar experience. If you're currently listening through your computer speakers, but if you prefer to dial in by phone, simply click the small arrow next to the microphone icon in the bottom left corner of your Zoom window. Select Switch to Phone Audio and follow the dial-in instructions provided. We welcome your thoughts and questions throughout this session. You can submit questions anytime by clicking the Q&A icon on your Zoom toolbar. Just type the question there and we'll be collecting them along the way and addressing as many as we can during our Q&A portion at the end. Feel free to use the chat box if you have any technical difficulties. Our team is here to assist. Also, today's session is being recorded and will be shared with you following the webinar. With that, I'm going to turn our presentation over to Kirk Treasure.
Thanks, Sam. Good morning, everyone. Thank you for joining us. My name is Kirk Treasure. I'm the Growth Director with Palm Beach ACO. Next slide, Sam. Next slide. Next slide. All right, a little bit about Blue Sky before we jump into some of the details. Blue Sky is a comprehensive analytics platform that offers much more than just quality reporting. It offers a full end-to-end financial performance suite, physician engagement as well to help providers stay on top of their population's performance, risk stratification, and a full utilization management, full utilization management suite for optimizing spend and resources. Next slide. Okay, with nearly a decade and a half of ACO data management experience, Blue Sky is the trusted and proven analytics provider for successful ACOs. It is an intuitive and easy to use, easy to deploy platform that currently supports over 20 growing ACOs to date, which you'll see on the next slide. Next slide, Sam. Okay, including Palm Beach ACO. So if you go to the next slide, with the help of Blue Sky, Palm Beach ACO has grown from an upstart in South Florida to one of the largest and most successful ACOs throughout the country, supporting 15,000 plus providers and approximately 700,000 beneficiaries across 32 states. With that said, I would like to hand it over to Amanda.
Thanks, Kirk. Good morning, everyone. So before I introduce myself, which is also up on the slide, and I'm looking through who's in the meeting, and it's so nice to see, all of you on here. I know many of you throughout the years. I hope quality reporting is going well. If it's not, really tune in, put your phone down. This webinar is certainly for you. So we're here together today because quality reporting is now different. It's different. You could have done it differently last year, but this is the first year of mandated differences. And so we're going to talk about how Blue Sky can help finish up your quality reporting needs. I mean, we're running out of time, so this is a very serious topic. So this slide is just going to tell you that I may be a little bit qualified to talk about quality, as I have done quality reporting for over a decade for Palm Beach ACO with very, very high quality scores year over year. Our physicians are very high quality, but you're going to hear why a vendor solution was needed for Palm Beach ACO. Next slide, please. All right, so there's some serious big changes, right? It's not the same. It's not the same as the web interface, right? It's the volume is significant. Are you guys feeling that too? When we went Medicare CQMs last year, the volume difference of, I don't know, what were my samples before? 2,800 to 3,500 maybe patients sampled. And last year, I was looking at 233,000 patients, wondering what I was going to do. And we're going to show you how we're doing so far now. And it's much greater than that, over 300,000. And we're going to continue to grow, and it's going to continue to get bigger. And this, you have to have a solution to scale. You just do. So, many changes, shorter measures, less measures, which is great, but that's also scary, guys. Think of a denominator of 110 and then think of a denominator of 70. That's really scary if you're not strong in a measure or you come up short on the performance. This is scary, and the benchmarks aren't always going to be flat, right? They're going to be performance based as the years go on. So these are all huge changes you all need to be thinking about how this is going to impact your organization. So, okay, so let's say you're ready to do Medicare CQMs. You got to go get a bunch of QRDA files. Well, what happens when the same patient is on multiple QRDA files from different practices? Maybe they see multiple doctors in your organization. That's noise. That's conflicting information. Like, how are you going to know which one to choose? How are you going to dedupe and put a timeline on that information and confirm that that information is true? It's truly a lot to think about. As mentioned, the volume shift is pretty significant. I mean, you went from a small sample to reporting on all of your fee for service, not even assigned, right? I mean, the doctors are saying, hey, Amanda, this patient's not even on my panel. And I said, well, you touched them and they're eligible, so we have to report on them. And if your ACO has specialists, this could be a dramatic shift, from what they're used to what you're used to. And data completeness, you have to be at 75% or greater on data completeness on all 4 clinical quality measures, not 3, all 4. And let me tell you something, that's hard, especially on depression screening. I could sit here for a long time and talk about how difficult this is. And I would not be able to do this without a vendor, without Blue Sky. There's just no chance. And this, obviously, just like any quality reporting, it impacts your shared savings eligibility, which can be really scary. That we all want that. That's our goal. So please, guys, take this really seriously. Next slide. Okay. So my question on this one is, do you miss the web interface yet? I did and do, from time to time. I definitely missed it last year when we made the decision to do Medicare CQMs early, which was, it was a risky decision. We came out strong. We're all better because of it. Our doctors are happy. Our board is happy, but I miss the smaller sample, right? This is just what we have to deal with at this point. We all are going through this. So it is just so important. And if you're wondering like where you're at, do you know your completion rates? Is that actually accurate? Can you convert it into a JSON file? All of these things. If you don't have confident answers, you're almost out of time. I want to say that I did a presentation last year on quality, and I looked at the scores, and there was a large polarization of scores, and you could tell the ACOs that still did, the web interface, which I don't blame you, right? You didn't need to switch over, so like why not, maximize something that we're all very comfortable with. And then those that moved, ECQMs, Medicare CQMs, MIP CQMs, the scores were just lower overall because the denominator was smaller. The volume was shocking. It was absolutely shocking. I'm still shocked we're reporting on this kind of volume. And I think that the industry overall is taking this a little bit lightly because I think we're all going to be surprised to see when everyone moves, right, for 2025 reporting. I think that the scores are going to drop overall. I think that ACOs are going to close over this. It's not going to be mine, but I think it's going to be that serious. And I don't want that to be your ACO. If you're on this call from an ACO, please don't let that be you. I mean, it's really serious. Please don't be the one that has to tell your doctors, right, that your ACO is closed or didn't make money because of quality reporting. Next slide, please. So, as mentioned, we did it a year early. There was a lot of thought that went into that decision, and I guess we did have the web interface as a backup, if we got near the end, which I wasn't super confident in that decision. Like this was the biggest project I had ever been a part of, ever at the ACO, in my career, in my life. The biggest one, and I'm not the only one that feels that way at Palm Beach ACO. We were definitely second guessing ourselves. I was one of the ones that was definitely second guessing it. Like, hey, when are we going to switch to the web interface? Like, when are we going to pull the trigger, to have a backup submission and it'll take the higher score? Like, when are we going to do that? And the team, we stayed confident overall, though I varied from that from time to time. And I wasn't sure if we were going to make it, just to be quite honest with you. We had weeks of hard work and challenges, weeks trying to figure out the logic, like how are we going to do this? And then once we got with Blue Sky and built out this incredible tool, which Kirk and TJ will be going into, it was followed by weeks of success. And it all finally started to click. As you can see here, here's our clinical score on the 3 measures. It was 3 measures last year. Now it's 4. They did add breast cancer on, and in 26, just as a reminder to my ACO colleagues out there, they did add colorectal cancer screening for this year. So make sure you have something that's keeping track of that. And we did really well. Here at the bottom is a snapshot of where we're at right now. I'm happy to say we've met minimum reporting requirements, so that's great. And we're working through the ranks in which Kirk will describe to improve our score and working through these QRDA files and all of the logic that's been built in for me and for you to make sure that the physicians, report the best score. Next slide, please. So I want to say every ACO is a little different. Ours has a deep data analytics and development department. We have some serious talent in those areas, in my opinion. And we still need this vendor. I am not confident that with that amazing team, I mean, really some of the best in the industry, that we would be able to pull it off with these kind of completion rates and performance rates. So if your ACO doesn't have a data or development, department, which some are small and may not, I'm not sure how you would do this alone. I'm really not. So Blue Sky, they meet you where you are. They take big ACOs, small ACOs, and these automated workflows are scalable for any size. That's what's great. Tons of dashboard options, which is awesome. I pull different dashboards multiple times a day for different people, the doctors, our field teams, my leadership team, and we can parse the data in ways that are actionable and get the point across to the right stakeholder. Super easy interface, we use Blue Sky for other things like our analytics and utilization metrics. And they can just go live for quality. So even if you have an analytics vendor, you don't have to use it for that, though they're good. This is about quality reporting, in which you can just do with them. It's super easy. I'm used to the interface. Everything's drill downable all the way down to the claim. It's super quick. It's just a simple tool. I need simple when you're talking about volume of over 300,000 patients. I don't have another option. So I wouldn't use it if it wasn't simple, which it is. And the speed and collaboration, they made a funny comment one day, and it was very sly and under the radar. Oh, we can only process 80,000 QRDA files a night. And we're like, that seems like a lot. So I like to quote that because that's significant volume that they're loading overnight. And by the time you get into the office that next day, your completion rate typically pops up, which is a great confidence booster to continue your day with manual entry through the ranks, as Kirk will discuss. Next slide. This is just a small snapshot of the 2024, kind of shows my point on how many patients we have. We have a lot of unique practices in our ACO. Your ACO may be different. maybe you're one large practice, right? But this, we have a ton, and we have a ton of disparate EMRs. I mean, over 72. So what do we do with those files? Like that's all very overwhelming when you have that many EMRs and all of that coordination. And I needed somewhere central to put it, honestly, and do something meaningful with it to close gaps. This is kind of how we ended up last year on the bottom. Next slide, please. Lessons learned, I have many. Obviously, I have many to share. Um, but in a perfect world, by the way, we're out of time. Like teaching your practices to do CPT2 codes is good for next year. It won't be your solution to finish up 25 reporting, right? The claims are in, dates of service already happened, but just some advice for the future is certainly use your CPT2 codes, educate practices on that, where the EMR can be optimized, have your team go in there and update the templates and the workflows so that those automatically get populated based on the progress note. Working gaps in care throughout the year is obviously very important. You have to close the gap before the end of the year, or what are you going to report on, right? Like we need to actually not just identify there's a fail, but you need to try and rectify the fail and get the numerator closure that makes sense for the patient. Pulling EMR files, so this is your QRDA or equivalent files, getting those in Q4 is a great idea. It kind of helps close those gaps early as the performance year is almost over. So there are many practices in which we didn't have to repull, which was a great time saver for us. And track in Blue Sky. I track it every single day, every week, every month. We're always looking at the quality measures because we know this time, since we've done this before, we kind of know what to expect. We knew a little bit what to expect in 25. So we're on 26 for 25. So from last year, we were religiously looking at these dashboards and taking action, accordingly. Very helpful to establish connections if you don't already have them with major labs like LabCorp, Quest, recently BioReference, and so which is big in the Northeast. So these are all really good tools to help fill in metrics. And then on a side note, it also gives you good clinical data for operational initiatives throughout the year. So they're multi-purpose. The HIEs, which I'm sure you're all connected to in whatever state that you're in or whatever vendor you use. There's a diagnosis exclusions in there for the measures. So if you integrate that in, that's amazingly helpful to find patients that should be excluded from your sample. QRDA files and MIPS dashboards, which TJ will cover a little bit. Fire data is great. That's some automatic closure right there. And, long-term solution or maybe APIs, which Blue Sky can connect and integrate all of those tools in which I had just mentioned. So this is a pretty good stat. I'm glad the team put it in here. With all of these gap closures, automatically through these means in which I just discussed, including CPT2 codes, we've saved over 2,000 business days. So I don't have 2,000 business days for quality reporting, and you certainly don't either. I think we're down to the wire. So you need something that's going to get this done and get it done right. Next slide, please. Awesome. Well, I'd like to pass it over. Thanks for letting me talk about, my experience with that. And please, again, if you're not confident, if you feel behind, if you haven't gotten good dashboards, you need to act now. You need to reach out now. So you can, I just don't want you to have to tell your docs that there was no money. You didn't hit 75%. You didn't know you were under 75%. We care about all of you. We want all ACOs to be successful. We truly mean that. So please, if any of this clicked with you, let's talk offline. But I wish you the best in quality reporting season. It's almost the deadline, so please act now. And TJ, my colleague here, who's a little bit more on the technical front, will cover some amazing topics. So please make sure you take notes. This is all really helpful advice. Go ahead, TJ. Thank you.
Thanks, Amanda. So I think some of you guys, like Amanda, I recognize some of you from the great conferences and in person. But for those I haven't met, my name's TJ Leach. I'm the VP of Innovation here at PBACO. So I kind of have two roles. The first is I run our ACO reach contracts, including our regular reach and then our high needs. And then my second is I lead our team of EHR specialists and work through kind of the finite details of getting the files and working on optimizing workflows, getting templates installed, auditing practices to make sure that they're filling things out the right way. That's what my team on the EMR front is really focused on. But I have a lot of experience with the old school quality reporting as well. I was working with about 6 different ACOs before I came over to PB. So next slide, please. Jump into the fun stuff. The challenges with CQM reporting. You guys have been doing that. You guys should be doing this. You guys should be aware of what some of these challenges are. But we have a ton of different unique EMRs that are all cert that don't always interact together exactly the right way. So 70 unique EMRs with inconsistent data structures. A lot of times our practices are documenting in non-exportable fields. We've got templates that will run where they're putting it in non-discrete fields, and it just doesn't make its way over to the QRDA data, which is why pulling these QRDAs and these dashboards early is so important. And then we have vendors and EHRs who are charging fees to get the QRDA files, which can always be very, very tough. We at PBACO have a unique challenge with our number of multi-specialty groups. A lot of times what we're finding is that specialists are triggering eligible encounters for unassigned patients. That's why one of the reasons why our reporting requirements are so high is because we see a lot of that. And we had a hard time last year, for performance year 2020, for performance year 24 reporting, figuring out how we wanted to incorporate that data and how we needed Blue Sky to kind of comb through and kind of cut through the noise to get it to a place that we could actually accurately report on. And then, we have discrepancies between specialist workflows and what CMS requirements are. Not all specialists are doing depression screenings because it's not part of what they are expected to do, and it's not part of how their practice is set up. But CMS didn't really care, and they said it doesn't matter, that you're still required to report for those. The specs have cleared up a little bit since last year. We don't have as much of this problem, but we still do have some ambiguity around measure logic, eligible patient populations, things like that. And then I saw a question in the chat about claims data and missing claims data for the patients that are MCQM eligible. Absolutely a major issue for us. And we see it a lot with our specialist population in comparison to our PCP population. So as a retrospective ACO, I think we may get some more claims than some other groups do. But we don't get a lot of this. A lot of the stuff on the specialist, we kind of we're going in a little bit blind. And then we put in some things within Blue Sky to help us identify where we have gaps. Where does claim show something and we don't have that from clinical data, and vice versa. So we do have that. We do have those gaps in kind of both directions as we work through, that BSA has been able to help us solve for. Next slide. So one of the ways we really wanted to solve for the QRDA mismatches and how tough it could be was to use CPT2s. So we worked with Blue Sky to identify the right CPT2s that we wanted to identify. I'll touch a little bit more on exactly what I mean by that. But we saw a significant growth from 2023 to 2025. We had Blue Sky help us start tracking the codes that we wanted to see. And we've seen a noticeable uptick. So when we talked about this last year, we saw an uptick in the start of 24 to the end. When 2024 wrapped, we had about 300,000 CPT2 codes. For performance year 2025, with pretty much the full year of us like really heavily pushing, we actually got up over 500,000 CPT2 codes entered individually onto claims. That helped us to pre-identify groups that we knew were going to be problems when it came to quality reporting and helped us get in front of it. One thing that one trap that we can fall into with CPT2 codes, and this was a lesson learned that we had from performance year 2024, was that a lack of something happening does not always necessarily mean it was a fail. So one thing we worked through a lot with Blue Sky was, where do we want to take the passes? Where do we want to take the fails? What makes the most sense as a hint versus automatic passes? We saw that kind of in the specs of the measures that a fail a lack of a screening is a fail code, which is 100% accurate. But what we were finding was that specialists were billing those lack of procedure codes, and then that was kind of an inappropriate fail. So a lot of work on making sure we're using the right CPTs to close out and really get the most actionable work in front of the practices. Next slide. EMR integrations. That's kind of the second piece. That's a little bit more as we get into real time. So we're pulling QRDA files, we're pulling MIPS dashboards, and then we're also kind of late in 2025, early 2026, we were working really hard on direct EMR integrations through APIs. As we pull that information out, that is also passed into Blue Sky to see how many gaps we're closing, how many patients we're identifying, and then using that to create our work list and where we really need to put a lot of our time and energy and focus. This is an example of the QRDA impact report. This one is actually new for anyone who was on this webinar last year. This is something new that we got for that Blue Sky created for us for this reporting period. So this will show each individual practice, how many rows, how many individual files were loaded into those QRDAs. So each file represents a singular patient. So practice A, there was 168,000 patients. 21,000 of those were processed, meaning that they were matched to somebody in the Medicare space. And then under the high blood pressure, the patients that qualified, we had 26 that we were able to close. 26 of those were passes in this first scenario. We didn't have any fails, and then we had 54 that were incomplete. And we used the match to incomplete to help identify, hey, maybe something wasn't working right with either with the file or the practice wasn't documenting the right way. And those are cases where we can go and look in more detail. Kirk can set up some time if you guys have like some more specific questions around how this works, to just show how this how we use this and how this has been beneficial for us. Okay. Next slide. So from an expansion perspective, what are we doing with with CQMs going forward? The APIs, we got those late in the game. So really excited as we have, right now we have ECW and Athena established, and we're working towards additionals. Those direct integrations are going to help us close gaps a lot earlier. One thing to note is just because you have the link and why it's so important to run these in through a vendor early and run them through often is just because you have the integration. It doesn't mean that you're going to get passes, even if the practices are actually doing are trying to close the measures. Just because you have an integration doesn't mean that it links. It doesn't mean that it's always in discrete fields. So getting it early is going to be very, very important. We're looking at additional lab vendors and additional sources for us to get claims from, as well as looking at preferred provider EMR integrations in the future. So some of our specialists, how can we make it easier for us to find that specialist data? And the next slide, please. So from the EMR perspective, what did we learn? What have we been trying to address? You need to make sure that your practices are using structured data fields. You want to pull the files You want to pull the files early. You want to process them through your vendor like Blue Sky to make sure that you're actually getting real closures and not just and things are documented the right way. You want to drive the quality improvement year round. Seems like an obvious one, but you don't want to wait until the last minute to figure out that you have a problem with how practices are documenting. Vendors who listen and adapt to what you guys need, very, very helpful. And then really like one that we were a little surprised on was like those false failures. So make sure you avoid those like false failures from the CPT2 codes, because that could be a trap that's really easy to fall into if you're not paying attention. The last thing I'll say is that, and Kirk will go into some more details of how we use the hints, but a lot of vendors can help link the data. A lot of people can help you dedupe and just run it through. Because Blue Sky was started by ACO operators and has a history of helping ACOs for so long, they're looking at not just how to link the data, but also how to help close the gaps and how to collaborate with the ACOs to get the best scores. If you just run a QRDA file through, you might have a 60% pass rate, but where Blue Sky helps is how can we turn that 60% into an 80% or into a 90%? Our QRDA files are not perfect. Our EMR files are not perfect. And Blue Sky has been instrumental for us to get to the 90th percentile of 3 of the measures and probably getting to the 90th percentile in all 4 before the year is over. So with that, I will turn it, back over to Kirk. Thank you everyone for your time.
Awesome. Thank you very much, TJ. Yeah, I think a lot of the guests we have on the call today, I hope they benefit from some of our learnings working with Blue Sky and what we were able to kind of, the holes we were able to step in and move forward, and hope they could take some of that away from them. So a little bit more about Blue Sky. It is a fully integrated, comprehensive platform, right? It's one partner, one platform, and it delivers proven, tangible results. Next slide, please, Sam. So CMS knows that this is a heavy lift, right? And I think without reading this verbatim, basically what they're expecting is that you do your best to get the data, manage the data, and what you submit and what you report, you can stand behind. And the best way to do that is to have a team behind you that can actually aggregate that information and give you what you need to support, what you submit to CMS. Next slide, please. Okay, so what we do, Blue Sky aggregates data. It becomes your true point of your single point for data, your single source for data, your true source of data. We match the data. We deduplicate your beneficiaries. We go through a full data validation process to make sure it's as clean a data as you can have. And after we go through that, we do prepare the JSON file, or Blue Sky does prepare the JSON file in the format you need it, and as complete as you need it, so you can submit that to your APP and to get your quality reporting done for CQM. Next slide, please. Okay, it is an analytics, and I think that's one of what I'd like to kind of push home. They're a true data analytics company. They can source and manage data and receive data from any source we collect, and receive data from your claims, lab data, EHR data. They do a lot of manual extractions when needed, and prioritizing the data sources and where, how we get those in, it really helps, because, claims data will help, and your CCLF file will help you with your hypertension measures. Lab data will help you with your diabetes measures and get those taken care of. EHR data is extremely valuable in helping with your hypertension as well as and depression. Depression is a little bit difficult, but it does help you, by collecting the multiple sources. We do a really good job getting those gap closed because of all the expertise they have in managing different sources of data. Next slide, please. Okay, monitoring and ongoing support. So Derek and the guys over at Blue Sky are very, very, very bullish on this, right? Because they want to make sure that their partners feel supported, and they do support their partners around the clock, year round. So from the loading the beneficiary files, identifying and closing gaps, doing the quality checks. One of the nice things about Blue Sky is that we've automated the quality checks in the system, and providing round the clock support and giving you access to at a glance view to look at the dashboards and know how you are performing in your measures is a key thing for the team over at Blue Sky. Next slide. Okay. Yeah, something else very important to be compliant. Full adherence in CMS rules. They do help you with doing your audit readiness and preparation, and they stand. I think one of the things that you'll hear repeatedly on this presentation is that Blue Sky is instrumental in helping ensure compliance for the ACO partners. Next slide, please. Okay, so yeah, let me share a couple of dashboards and screenshots for you so you can actually see what it looks like and see that it is a real solution. It's not vaporware. So these are examples of a couple of dashboards that we have in Blue Sky. And one of the nice things about this is that it's an at a glance view. Real time, you can look in to see exactly where you stand. Who your eligibles are, what gaps how many gaps you have open. You can see that at a glance. And I have, quality leaders for our clients today that would look at this thing almost every day really quickly just to kind of see how they're trending, right? Data completion, very important on the far right here. I know it's a little small to read, but it really keeps you on top of things and make sure you're not falling behind in areas that are critical for a successful reporting. Next slide, please. Okay, so prioritization is a big part of everything Blue Sky does. So we have work queues. They offer work queues in the platform that allows you to rank, prioritize how you're going to approach your measures, and they do a really good job sort of creating color-coded rankings for you. So rank 1 is your assigned PCP data. 2 is your participating provider data. And before I continue, all the information, this is pulled from our sandbox. So all the information is de-identified. So none of these are real patient information. Then fails, rank 3 is your fails by assigned PCP or data mismatch that you could work. But what's nice is that if you drill down into, let's say, go ahead, what's the next slide? If I go ahead and hit the eye here directly from the screen, it will pull me up into, giving me my hints, and it prioritizes hints, as I mentioned. So here we see that this is incomplete, but from here, it's pretty small. Let me see if I can read that. So it gives you your hints from top to bottom. So here I could see it's an AWV depression, it's incomplete. And I can see that a screening was done on May 30th, and it links the claim, so I could drill down and look at the claim directly. If I need to confirm with the PCP, I can talk to the PCP about the claim. But from here, I can very easily, close the claim from here, or I can continue to, answer the information manually. I think that says, is the patient qualified for this measure? So you can hit yes and close that gap in care if needed. Blue Sky is as I mentioned earlier when we started, it is a comprehensive tool. So it's not just quality reporting. You do have access to add additional notes directly to this patient file. You can drill down into the specifications of this measure. It allows you to go to access the full patient profile from here. So if you want to see, other diagnoses or plans on the patient, you can do that. And if you want to upload documents directly into the system, like this, maybe I don't know, this is for like a PHQ 9 or PHQ 2 document that you have, you can upload it directly to the patient chart from here as well. Next slide. Okay, another example of performance met. So here we can see that there's a, which one is this for? This is a depression as well. So here you can see that the performance is met on this one. You have all the details where you can drill down directly into, I think this is the primary care provider. We know that it's been coded and reviewed and there's no further action needed. So, the hints will give you exactly what's necessary from here. You can, next slide, please. Okay, Prep 5. Okay, again, another example. No further action needed. Radiologist notes here. The primary care provider also has that the screening was completed, and other encounters where you can see that they have CPTs specific to their breast cancer screening and care plan. And here it also lets you know that, no further action needed. You can go ahead and that measure has been closed, and you have the P. So we also give you indicators. So you can skip the measure if it's not relevant. Maybe your patient don't have diabetes, so you'll skip that, the diabetes measure. P is for pass and I is for incomplete. And as you can see, if you drill down into the I, it does give you really good direction on how to approach that measure, and you can close it directly from the view if it allows you to. Next slide. Next slide, please. Oh, there we go. Oh, cool. All right. So, when performance is not met, so we have this one. We'll look at the depression screening. So we do give you the ability to have like, quick confirm passes, right? We don't allow you to fail. The system doesn't allow you to fail directly from this quick access, but you can, if you do need to fail a measure, you can, underneath here is some questions that you can answer to close out that measure as fail. But again, you could do a confirm measure met screen negative. You can quickly select confirm measure met screening positive, and follow-up plan is documented, or you can mark it incomplete from here as well without, as a just kind of a quickly navigating through that. So we do make it easy. Like I said, they prioritize ease of use on the platform. It is robust, but it's not complex. If you, let me see what the next slide is. Is that it? Is this the last slide, Tim? Should be. Okay, cool. So a couple of things I'd like to say is that if you are an ACO that has not put together a plan or don't know how you'll be submitting, or kind of, waited till the last minute for whatever reason, please reach out. Blue Sky is an excellent company. They are a data company. They are proficient with ACO data, and they can have a portal stood up for you very quickly once they receive the data, and you will have enough time to be able to meet your reporting requirement come March 31st. So yeah, that's all I have.
Thanks, Kirk. Thanks, Amanda. Thanks, TJ.
Absolutely.
We did have a few questions come in, so I'll go ahead and read those, and whoever wants to answer can answer. What percentage of your data was not captured from structured data, and did you collect any data manually?
There's a good amount of data that we collect manually. There's kind of two components. So sometimes we get the data from structured fields, and we have the practices or kind of the staff go kind of work through some of the ones that we get because it's unclear. I'd say somewhere between 30 and 40% of our answers have some user interaction to kind of confirm that it's the right pass or the right fail. Our number is probably a little high because of the number of specialists that we have and the sheer number of specialists that put data into put patients into our denominator. So I'd imagine that if you structured it the right way, you'd have a significantly less than we do. If you structured the data the right way from the integrations and you don't have as many specialists, it probably wouldn't be as much, but for us, it's somewhere between 30 and 40%.
Thanks, TJ. Another question that we had come through was, as you noted, you have data that is not going to come through integration, but still need to report on. For example, like depression remission follow-ups across your ACO. How much manual abstraction are you still doing after full integration from EMR to Blue Sky to capture this performance? Is that one you, TJ? More integration questions?
I can start it. Maybe TJ can finish it. So it depends on how the practice uses their EMR, we can install everything in the world, but if they skip discrete data fields that wouldn't be pulled from an integration or a file, the issue still persists and manual entry would be obviously required from time to time. I'll let TJ jump in and go from there.
I'd say I think it's the same. To
Yeah.
me, that's the same question as the last one, which is somewhere between 30 and 40% have some sort of manual interaction. I think I think maybe there was a kind of a miscommunication. Our providers, they have to select fail if the patient doesn't have what's required to pass the measure. So you are allowed to do the fail in the manual abstraction. I see this question come up in the chat. What we did is there was a quick select option that allowed practices to fail the measure. And what we found, and the reason that we removed that for 2025 reporting is because practices were using the quick fail because they didn't have the information in their EMR. But then we actually found conflicting data from the community, and we were unable to determine because the quick fail doesn't have you run through the prompts of answering each question. We actually removed it because we couldn't easily determine why the fail happened. Was it a fail because the last visit you did a depression screening, or is it because you didn't have a documentation of a depression screening? And we would see that there was another claim that had a depression screening completed, and we would try to collect that record. And then we got into a little bit of we had to push it back to the practice to say, well, you don't have it. You failed. Does it fail because you did it on 12/2 the last time you saw them, but I have a passing depression from 7/1, or is it because you didn't do it on 12/2? So when we do the fails from the manual, we require the practice to answer the full set of questions. So for depression, it'll be like 3 or 4 questions to indicate why they're failing it, and that way it makes it a little bit easier for us when we do score improvements later on. So I hope that answers the question. But yeah, we just took it away from the quick option.
Thanks, TJ. I appreciate you clarifying that. I did have one more question that we wanted to, or actually 2 more questions. One, how do you train clinicians and billers to effectively use CPT2 in HCPCS codes for quality measure reporting?
A lot. The right answer is that you just you're constantly reinforcing, and then you need the vendor that can help you identify from the claims when you're seeing it. So if you're not tracking it from the claims and you're just doing the training, then you're only going to have half of the information. We put in as many automations as we could. So there's ECW I'll use as an example. They have it's called the clinical rule engine. So you can, based on this value, you can have it generate a pop-up to help them put the CPT2 code in. Practice still has to agree to it. They still have to do it. And then it's just a decent amount of kind of checks to make sure that everything is working. And then you're seeing it come through in the claims.
Perfect. I thought that was an important question. And then the last question we have is, can we directly synchronize the care gap data with claims data to check how many have been closed?
Yeah, absolutely. That's kind of our big one right now, is that especially with the EMR integrations that we're working through, we're expecting that our gaps in care data is going to be significantly better. So we'll use the claims and identify the patients that we want to target and that we think are going to qualify, and then we'll close out if we have CPT2 codes or something that can close that measure, and then we'll back that with the EMR data to make it the most actionable list for the providers.
Awesome. All right, one more just come in. And an A1C is valid no matter where it was done. How do you handle depression screenings done outside of the ACO? Do you use that data?
We collect the records. Provide that back to our PCP so that they have it noted in the chart. But absolutely, we're looking for depression screenings wherever we can find them. Depression is unfortunately one of the hardest to find. And lab data is really easy to integrate. Like, we've gotten a lot of really, really positive results from the lab data. We do not have a lot of manual work we don't have as much manual work on the A1C side. Depression is where most of our manual work is done. So we'll use anything we can get our hands on.
And most patients qualify for depression screening. So it's good to have that done throughout the year and being monitored.
Mm-hmm.
Well, I appreciate everyone's questions today. They've been great. And I truly appreciate Amanda, Kirk, and TJ taking the time out of their busy schedule, especially during quality season, to bring this valuable information to our network. So with that, thank you for sharing these insights and the expertise, and we appreciate everyone that has joined us for this informative session. As a follow-up, we'll be sending an email that includes the presenters' contact information should you have any additional questions, along with a link to our webinar recording. Please share this with your colleagues or peers who may be finding trouble closing out some of these gaps. We appreciate your participation and encourage you to keep an eye in your inbox for upcoming announcements and future webinars. And also just a quick reminder, conference registration for the Texas Association is open. We hope to see you all in Texas, May 4th, 5th, and 6th. With that, everyone have a great day and a great rest of your week.
Thank you. Thank you all.
Thank you.